Our next speaker is going to be Kayla Thibodeaux. Kayla is a clinical pharmacist extraordinaire who makes my daily life so much easier. She's going to be talking today about pharmacogenomics in pediatric cancer, something that she knows really well. She did a training at St. Jude's in pharmacogenomics for peds. Kayla.
Well, thank you very much for the kind introduction, and thank you everyone for showing up today for my talk about pharmacogenomics and pediatric oncology. Today my talk is mostly going to be just about the application of pharmacogenomics in this patient population, but I also wanted to bring to light some ways that you can possibly incorporate it into your clinical practice, as well as some future directions to look forward to. So I don't have any financial disclosures or conflicts of interest. So by a show of hands, who knows what pharmacogenomics is? Great, that's awesome. I'm so happy to see that. So just to get everybody on the same page, so pharmacogenomics, we can kind of split into two words, pharmaco referring to pharmacy or medicine, genomics referring to the genome or DNA. So it's really about how the genetic variation of a patient contributes to the variability in their response to medication. And pharmacogenomics really is just a branch of precision medicine, and it helps us to understand a little bit more about why there's variation in therapeutic response, as well as why some patients have more toxicities or adverse effects compared to others. So whether you have pharmacogenomics in your current practice or not, what's on this screen here is sort of a universal experience. So we have on the left a patient population. Let's say that they have the same diagnosis, they're going to receive this same little blue pill, they have the same dose and the same schedule of this medication. And then what we see is on the right that we don't have the same response among everyone. So there's those people in the green who have exactly what we want. They have the therapeutic response with very minimal toxicity or adverse effects. But then you'll also see on the other hand this yellow group who have no response to the therapy, or even the patients in red who have toxicity. So as you can see, this is not a one-size-fits-all approach to anyone, so we have to make it a little bit more personalized. And so why is this? Why do we have to do this? There's lots of things that impact how a patient responds to medication, and pharmacogenomics or genetics is not the only thing. So there's multiple pieces to this puzzle that have to be taken into consideration, like intrinsic factors, which we already are considering. So things like renal function and the patient's age and whether they are obese or not, all these things, as well as other external factors like diet and exercise, drug-drug interactions, smoking and alcohol consumption, their environment, whether they're actually taking the medication. All of these things come into play on whether a patient will respond to therapy. So there are two main methods of pharmacogenomic testing, one being reactive and the other preemptive. So I'll explain this to you a little bit, and I'm sure that we all kind of have a little bit of a mix of which one we practice with. So reactive you can think of as, okay, I'm contemplating prescribing a medication, or I am prescribing a medication, and now I'm going to get pharmacogenomic testing. Sometimes it's even done in the retrospect. We give a medication to a patient, and they have a severe side effect, or they're not responding as you expect to, and then we get pharmacogenomic testing, which would then change their therapy. And so the way you can think about this is like a just-in-time approach versus preemptive is whenever you're collecting this information about pharmacogenomic test results before the patient ever needs the medication. And a lot of us are kind of on the more reactive side, but if you're doing panel-based testing, there is also a factor of preemptive as well. So this preemptive method is actually more of like a just-in-case method, so just in case you need it further down the line if a patient were to be prescribed clopidogrel or a thiopurine, etc. And so there's actually a little bit more that goes in between distinguishing these two types of tests other than just the kind of sequence of ordering. So turnaround time, or the time in which you have the results available, is another thing to consider. So when you're doing a reactive test, you also have to think about the lag time of the time you're ordering to the time you get the results back, which could be several days to even a few weeks, versus when you're doing it preemptively, you'll have that information readily available at the time of prescribing. Also, prescriber knowledge is going to be important here too, because if you're doing it reactively, you have to know about the gene that you're going to order a test for, right? in order to order that test, versus if you have this information available preemptively, there can actually be decision support built into the EMRs and things that'll flag you whenever you actually order the medicine that says, hey, you have this result, why don't we try this dose or try a different therapy. Cost is another variation, although both can have possible panel-based testing. So typically whenever you're doing preemptive testing, you're getting a whole panel of pharmacogenomic results versus preemptive when you're usually ordering a single gene, although this will vary by institution. So yeah. And so another thing I wanted to also talk about is just how ongoing research is really just shaping everything in healthcare, but it's also really strengthening the clinical implementation of pharmacogenomics in our practices. So pharmacogenomics, like everything else, starts with discovery research. So we first start out with identifying drug-gene pairs or variant alleles that have an implication on a patient's response to a drug. Then we take that further and study the mechanism of why, what enzymes, what is the reason for this, and then eventually we'll take this and bring it into patient care and bring this pharmacogenomic information to the bedside. All right, so now we're just going to talk a little bit more specifically about pharmacogenomics in pediatric oncology, mostly just going through why it's important. So the first reason is because many drugs in pharmacogenomics and in pediatric oncology have the CPIC-guided drug-gene pairs, and every individual is actually likely to harbor some type of actionable variant if you were to do a full panel-based test. So if I was to actually provide a panel-based test to everybody in this room, 95% of you would have one result that would be considered what we call high risk or actionable, which just means that you'd have a result that maybe down the line, if you're prescribed a medicine, you would have to have a change in dose or a change in therapy. And then taking that further, you see on this chart here that there's even like a 31% of you that would have more than one, so you have two, and then another about 30% would have three or more, et cetera, et cetera. So it does make a big impact. And then also with our large and growing numbers of actionable drug gene pairs, there's just more research being done, more genetic variants, and these associations with medications being found. It's a very booming space, and so there's lots of opportunity further down the line as we gain more research. And so I wanted to bring up the idea of a poster gene for pediatric oncology. So a lot of the times when you hear about oncology and precision medicine or pharmacogenomics, one of the big poster genes that they talk about is DPYD and fluoropyrimidines, so 5-FU, capecitabine. But in pediatric oncology, we really rarely use 5-FU. It's not something that we use a whole lot. So I figured we'd kind of take a step back and think about one that would be good for us, and I think TPMT and NED-T15 is definitely one that is most prevalent in the pediatric oncology space. And like we saw in previous presentations, ALL is our #1 malignancy in pediatrics. And then with that, thiopurines are like one of our mainstays of treatment for ALL, so it's very common. And then we experience this with patients all the time. There's just a varied response to therapy. There's lots of myelosuppression, low counts, delays in therapies, dose reductions that are seen very often. And another reason that I think this would be a good poster gene is because it is one of the very first pharmacogenomic relationships that we were actually able to identify. So it was actually one of the very first pharmacogenomic associations that was actually discovered. So mercaptopurine actually came to the market in the 1950s, and then we actually found the link between TPMT and thiopurine use almost 36 years later. And then from there, we were able to start incorporating single gene tests into our own clinical practice so that we can test patients and see if we have to make dose adjustments. And then from there, we gathered lots of data from patients and max tolerated doses to eventually develop our first CPIC guideline about TPMT genotypes and thiopurine dosing. NED-T15 actually came back much later where we actually identified that one, and the link there was discovered in 2014, and then we modified those CPIC guidelines in 2018. All right, but the timeline does not stop there. There's actually been even more evidence and data come out recently that's still shaping guidelines. So there was actually a study done in 2024 about the additive effects of TPMT and NED-T15 on thiopurine toxicity in children with ALL across multi-ethnic populations. So this study was done in 2 segments. They first had a clinical segment in which they looked at over 1,700 patients who were genotyped for both TPMT and NED-T15 and had received mercaptopurine at the standard dosing. And then they also looked at these patients and kind of compiled all of their genotype information and found that there was only 22 of those patients who possessed a TPMT and NED-T15 intermediate metabolizer status. So before this study was done, and kind of the reason it was done, is because they were seeing in clinical practice that the dose recommendations for reduction for a patient with either a single gene of TPMT or NED-T15 intermediate metabolizer or both was the same reduction. But they were seeing that these patients who had both intermediate metabolizer status actually needed even further dose reductions. And so the study was done, looked at these patients, and sure enough, their maximum tolerated doses were actually much lower than those who either had a single intermediate metabolizer status or they were normal. And so then they took this information and they brought it back to the lab, and they did it in mice models. So they genetically modified the mice to express either one or both of those intermediate metabolizer status and saw a very similar thing in that they had earlier toxic death whenever they had both with the standard dose recommendation. So what this led to was a shift in our guidelines to now include new recommendations for patients who are compound intermediate metabolizers for both TPMT and NED-T15. And this is incorporated in both our CPIC guidelines, and this is actually a snippet from one of the most recent ALL protocols from COG. And so what I talked about before about how this is really strengthening and helping to implement pharmacogenomics into clinical practice, it also goes back around to this big feedback loop. So now we're learning more after it's been implemented into patient care and bringing it back to the benchmark and then bringing it back to bedside again. So it's this lovely loop of ever-evolving information. So another reason why pharmacogenomics is important in pediatric oncology is because there is a high frequency of prescribing of medications that have a pharmacogenomic impact. Oh boy, all the stuff is glitchy here. But I'll kind of try to explain this to you. So this is kind of just showing the frequency of actionable, well, not frequency, the amount of actionable medication use, pharmacogenomically actionable medication use in a group of pediatric oncology patients over a 10-year span. So it was just identifying patients who received at least one of these drugs or drug classes on the right-hand side that you can't even see. But all this is showing is that there are hundreds and thousands of patients who are receiving these medications in this space. The top 5 that were shown were ondansetron, the NSAID class, thiopurines, of course, PPIs, and voriconazole. So there's lots of these medications that are commonly used in our pediatric oncology space, which makes it useful. And then lastly, and I think one of the most important reasons why it could be so useful is because there is this unique long-term benefit of our pediatric oncology survivors that we can continue forward this information. So childhood cancer survivors live decades beyond their treatment. So we are treating 4 and 5 and 6-year-olds, and sometimes even younger than that, sometimes a little older, but that just means that they have a lot of life left to live. So pharmacogenomics can be very useful in preventing and reducing long-term toxicities to their treatments, as well as kind of preventing those other things down the line. So unlike adults, these pediatric patients must carry these consequences of their chemotherapy exposure across an entire lifetime. Another thing that I used to say a lot whenever I was in the pharmacogenomics clinic is that genetic results are lifelong. So this is really great because That's not likely to change with some exceptions that I'll talk about later. But a child's pharmacogenomic results can be used for future medications and medication use. And we know that these patients maybe will have some other chronic conditions associated that will have other medication use. So it's best to, if we can, do panel-based testing to help have all that data available in a preemptive manner. So, like I said, are they really lifelong results? There are some caveats and exceptions to this. So the DNA itself, of course, is lifelong, but the interpretation of the results may not be. So there's always new evidence, and even what we saw with TPMT and NEC-T15, new guidelines or shifts in guideline recommendations. There's hundreds of drugs trying to come to the market every year, so new medications and possible other associations with genetics will also come forth. And then also reclassification of variants and even identification of new variants in a population can also make the interpretation different. Testing methods also matter significantly. So there's also newer technologies that come about where they have new variants that are tested that were maybe not previously detectable. So thinking about those things whenever you have a patient who presents to you with results that are from 10 years ago. The use of copy number variants, so there's still some testing out there that does not report copy number variants, which is actually very difficult to actually use in clinical practice because the results are very misleading. And then whole genome sequencing. So right now, a lot of our pharmacogenomic testing is done by SNP array testing, so just trying to detect whether a patient has a presence of a specific variant. Whereas whole genome sequencing, you see everything. So if there's a stop codon that happens before you even translate the rest of the protein and things like that. So other things to consider about testing methods. And of course, there are instances in which a genetic makeup of a patient can change. One of those being allogeneic bone marrow transplants, and then liver transplants as well, also make an impact on that and the associated genetic chimerisms that can happen from that. So I also wanted to bring to light, if you have pharmacogenomics in your practice currently and are looking for ways to expand, or if you're even in the implementation stages and looking for places to bring pharmacogenomics forward, I think that survivorship clinics are actually a really great space for pharmacogenomics. So these visits really provide opportunities to educate and re-educate patients. So thinking about patients who maybe you've treated at the age of 12, and they're in survivorship clinic now at the age of 18, they may not have understood what these results meant at their initial time that you presented it to them, but now can take it forward and further be aware of it and bring it to their providers. And with the education piece, it's also very important to educate patients to show this to other providers outside of where you're practicing. So patients are likely to move around, go to college, move their life. So just making sure that they bring these results forward to other healthcare providers and institutions. Also, this helps to optimize dosing for medications and chronic conditions that these patients will have later on that maybe you're following up on for these patients. And also just creates a really good bridge to adult care. Okay, and now I'm going to talk about a little bit of future directions, things on the horizon in pediatric oncology and pharmacogenomics, kind of a mix of the two. So I'm sure you guys maybe have heard about irinotecan and UGT1A1 and considerations and dose reductions for that. So there's actually evidence review underway through CPIC, which is the Clinical Pharmacogenomics Implementation Consortium, to publish a guideline on this. What I did want to bring to light to this group is that I think that there's going to be a pretty big difference in the dose recommendations for modification for adults versus pediatrics. And this is simply because we dose things much differently in pediatrics for irinotecan specifically. So adults typically get like 125 to 180 per meter square in one single dose, versus in pediatrics we do over 5 days in little chunks of 50 milligrams per meter square, which I think also will make a difference on the toxicity overall. Another thing that was identified recently is the association between CEP72. There's a variant that they found there. This gene actually codes for microtubule formation in some kind of a way, and it's actually believed to have increased risk for vincristine-induced neuropathies. So there's ongoing trials right now that's actually clinically enrolling patients to receive a reduced versus a standard dose of vincristine for patients who have this variant specifically in ALL treatment, and seeing the difference between both efficacy, safety, and like the toxicity profile there. And then artificial intelligence, there was a whole talk about that this morning, but I think that this is going to be another avenue in which we see growth for pharmacogenomics as well. So there's possibility of combining multiple data streams within an electronic medical record, where we can take different patient factors that we talked about before in that puzzle piece section. So taking into account age and renal function and labs and pharmacogenomic results and giving us a precise dose to give to a patient. Also, it can be very important and helpful in helping us find more actionable drug-gene pairs for patients. So once we have the cloud of information of patients' full genome sequences available, it'll be able to kind of pull and see, well, with this patient and this patient both had to have dose reductions in this medication, maybe there's associated with this gene, and so on and so forth. I think that'll come much further down the line. But also can be very helpful in personalizing our survivorship care. So we already have a lot of these things built to help us see the cumulative doses that patients received of different chemotherapies within the EMR. But maybe this could go even further and incorporate other data points as well. Key takeaways, there was stuff there, I promise. So now you can just fill it in with your own mind and what you took away from this presentation. But it was a pleasure speaking with all of you. I really appreciate it, and I'm happy to take any questions that you guys might have. Yes?
So in your workplace, who's your favorite doctor? Me or Dr.
Okay.
Just kidding. So in your experience did you want to answer?
No, I don't. I'll plead the fifth.
In your experience with like different payers, insurances, have you run across like some insurances that will cover the panel, like the one on or yeah?
I haven't experienced it myself. I know we have some pharmacogenomic experts in the room at our institution who probably play more into the payer role, and I know that we have some laws in the state of Louisiana as well that help to make this more accessible and affordable for patients as well. So.
You know, find it funny that the whole panel that we're sending now is cheaper than the individual drug test.
Yes.
Right, yeah.
It makes no sense to me, but so it's standard.
You get more bang for your buck that way.
And one for vincristine
Mm-hmm.
on it?
Not yet. No.
But do you want to mention about that?
Yeah, sure, we can absolutely talk about that. So I will say that we do have legislation on the books about biomarker testing in the state of Louisiana, which was a CAGLA initiative, right? So they kind of don't training leadership there. The payer space has always been a challenge. We do see it, however, evolve. We know that there are multiple, both Medicare and Medicaid plans who pay for zero out-of-pocket for patients for panel-based testing. The commercial space varies widely, and can often, with prior authorization and that sort of thing, we usually get it.
So we should, do the pre-auth before draw mark. Running the test.
Do you guys happen to know what the cost of a panel is these days, cash price?
Cash is $350.
$350.
But I can tell you, at least like with our panel-based testing, all of the billing goes to our lab, and they will automatically enroll patients in their financial assistance plan. So if they have a really high co-pay that's not covered by their private insurer, they'll reach out to patients, and they're typically able to get it down between around $100. Yes, our experience that we have now are over 6,000 to 7,000 patients who can offer could have results, and if you take out the patients with zero copay, so all of your government insurers for zero out of pocket, on average our experience is around $110 to $130 per patient.
I guess along those lines, how would you counsel a loved one? Like your data, about 95% of us have a high tier variant. Like, do you know your own pharmacogenome? Do you
I do. Yes.
like, and your parent, like?
Yeah, so that's a really great question, and I had a lot of experience. So at St. Jude, they actually had just, whenever I was there, had just started a pharmacogenomics clinic, where the sole purpose of it was to educate patients and families on pharmacogenomics results. So a lot of these don't really have like major involvement where we have to call in like genetic counselors, but of course there are some instances in which we did. But it's just about kind of bringing it to the basics and talking to them and, you know, making it simple and making it easy to understand, as well as kind of just sharing the need to know, right? So we're not going to go and explain every single variant, like you have this allele and this allele. We kind of explain it as a whole picture. Like you have normal results here, but here we found that maybe for this medication, you'll need a dose reduction or a dose increase. So, yes?
A follow-up on that. Will we ever get to the stage where when a child is born, you do pharmacogenomics like a panel, so that for the rest of the life, the child know what
I think that's definitely on the horizon, and I think it'll go even further than that, and we'll just have their whole genome on day 2 after they're born from a heel stick or something like that. So I think that there's going to be lots of opportunity to have genetic information available earlier on in life to where it can be very useful and clinically utilizable
probably
future in life.
even before the child is born. Probably the parents want it done.
Yeah, even that, exactly. Absolutely, yes.
But maybe inconsistency with the star wheels that are being reported on
Mhm.
how do you navigate that?
Yeah, I think when it comes to being a pharmacist in the pharmacogenomics space, and especially in the implementation process, that is like the number one thing you have to look at, because you have to think about how this is going to impact the patient. You want to have the most up-to-date information, as well as making sure you're capturing all of the pharmacogenes that are going to be useful, that we have data for, and then making sure that those are testing everything that we need appropriately. So there's a huge comparison in all of these different panels to make sure of all of those things. But it's definitely one of the most important things in the implementation process for sure. Okay. Thank you all very much.